This webcast and any accompanying materials are copyrighted by the American Association for Respiratory Care. Any public display, sale, copy, or distribution of the video or materials may be undertaken with prior written consent of the AARC. Copyright 2012. All rights reserved. My name is Bill Dubbs. I'm the AARC Director of Education and Management Services, and I welcome you to today's webcast on the future of the respiratory therapist in home care. At the conclusion of the webcast, you should be able to recognize the historic factors that help establish the role of the RT in home care. You should be able to describe current reimbursement and market issues impacting on home respiratory care. You should be able to explain the new health care legislation and describe the activities that will impact on home respiratory care. And finally, identify new and future opportunities working for the RT, working in the home. I am pleased to introduce Joseph S. Lewarski. Joe is a registered respiratory therapist and an AARC fellow. He is currently Vice President of Clinical Affairs for Care Corporation, where he has worked since August of 2007. Prior to his current position, he served over 3 years as Vice President, General Manager of the Respiratory Group. Joe has been actively working in healthcare for over 28 years. He was most recently recognized with the inaugural 2011 AA Home Care Champion Award and is the past recipient of the American Respiratory Care Foundation Award for Excellence in Home Respiratory Care. Joe is a past president of the AARC Home Care section. He has published over 24 scientific papers in peer-reviewed journals and is a regular speaker at regional and national pulmonary medicine, respiratory therapy, and home care conferences. Mr. Lewarski discloses that he has no conflicts of interest related to this presentation, although brand names of products may be mentioned only as examples of technology. Joe, welcome to the program.
Thank you, Bill, and I'd like to welcome everybody, and thank you for joining me today, this afternoon, or this morning, depending on where you're at. So this is an interesting lecture because I said the text of a colleague just prior to starting this is, I call this my weatherman lecture, because whatever I say about predicting the future of healthcare and the role of the RT in home care is probably going to be wrong, because it's impossible, particularly in this environment, to predict where we're going to be. But looking historically at the business and what's going on in the current legislation, hopefully we'll be able to put some ideas out there that will make sense, and hopefully give you some ideas for your businesses as we go forward in healthcare in the United States.
Joe,
yes.
This is Bill. Would you please run your audio wizard one more time?
Sure.
Your presentation is a little bit muffled.
Bill, I'm back. Is it better?
Let's try it for a while. We may have to have you re-number. Let's try it for a little while. Go ahead, Joe.
Okay. Hopefully the audio is a little bit better, and you can hear me okay?
That is better.
Okay.
That is better. Yeah.
All right. Well, as we look forward, I thought I'd do a quick review of the past, and for those of you who haven't been working around home care, healthcare as long as I have, or some of the others I see names on the list of attendees, kind of where did we get our start. So this started, the whole home medical equipment business started as part of the Social Security Act of 1965, and DME was incorporated into that act. So durable medical equipment at the time was really the whole, again, this is 1965, so you'd have to think about where healthcare was at that point in time. Equipment was really the focus. It was about equipment that was going to be used for basically short terms, that was going to be generally reused, and so and really just for people with who's had some limited medical needs in the home. the clinical services element, particularly with many of the things that you do every day, weren't recognized as an element of this part of the benefit under the Medicare Part B Act.
Joe, I'm sorry, I'm going to have to stop you again.
Okay.
Could you try what we tried earlier
Sure.
to go out and come back in again?
Sure, I'll do that again.
Thank you.
Bill, do you want me to back out completely of the?
I think so, Joe. It's really muffled, and people are having a difficult time hearing.
All right. I'll
if you wouldn't mind.
Bill, I'm back.
Joe, you sound better. Go ahead and continue on with the presentation.
Okay. I apologize for any sound problems we had there. So here we go. So just to pick up where I left off, we were talking about the past. So really, where home care and particularly home respiratory care, where we started, kind of took off was in the mid-1980s. This was in response to a lot of the major healthcare changes and legislative changes that were occurring then. One of the biggest, of course, being the implementation of the diagnosis-related groups, or DRGs. DRGs started to have an impact on discharge planning and actually kind of the development of that, and moving patients from the hospital from high acuity outside of the hospital within some kind of time frame because of the DRGs. So also around that same time period, the Medicare hospice benefit was passed, which was around 1982. So the idea of home care started to evolve, not so much because people were thinking about the transition of patients into the home, but because payer systems changed and started to create an opportunity for the home market to evolve. Other things started to happen as well. Medical, pharmaceutical, and technology it was increasing life expectancy. We were doing things, particularly starting in the late 80s and early 90s, that was unprecedented in prior years. So we had neonates surviving, premature infants surviving, well under 40 weeks, 32 weeks, 28-week preemies started to show up. We started to have mechanical ventilation, patients transferring from acute care facilities looking for a place to go. So things started to evolve, and the opportunity to take care of higher acuity patients or patients with more technology needs began to develop in the home. As that happened, the fee schedules were kind of laid out. Again, all this was happening being really built around the equipment. If you look deep into the DME benefit, it's really a equipment benefit. It's based around a series of HCPCS codes or and a fee schedule that's tied to those HCPCS codes. In all of the legislation, RTs are not recognized as healthcare professionals. This applies both to RTs in the hospital, but especially it applies RTs in the home. In fact, within the national coverage determination for oxygen, it's very explicitly spelled out that respiratory therapy services are not covered under the provisions for oxygen under the Part B durable medical equipment benefit. And so all the care that we've done has been a result of the subsidization that came from the payments for the equipment. On top of that, the home care standards of practice are kind of limited. It varies by state. We do have some guidelines for particular products and applications such as oxygen therapy in the home, suction in the home, and manual ventilation in the home. And these come from the AARC CPGs, the clinical practice guidelines. The third-party accreditation does recognize clinical services, but this is a voluntary process. Bill, do you want me to keep going? We're still getting a lot of a lot of feedback
I'm not
people
sure
have
what we can do. I'm afraid it may be at the interconnection connection at your place there, Joe, and I don't know what we can do about that. I guess we could try going out and coming in one more time, because that one time we tried it before the show today, it seemed to work. If you don't mind.
All right, I'll give it one more shot. Okay, Bill, I'm back.
Okay, why don't you go ahead and continue on, Joe? We'll see how it goes.
Okay. So most of what we've been doing over the last 20 years in respiratory therapy in the home evolved from marketing ideas and tactics as opposed to necessarily scientific evidence or the clinical practice guidelines or any form of evidence. Much of what we were doing in the 80s and 90s started from hospital respiratory therapists transitioning to home, reaching back out to RTs that were friends or colleagues that worked at the hospital, which in much of the 90s, before the care management and case management models really began to take off, were the responsible parties for discharge planning oxygen patients and patients with other respiratory things. So many of the protocols that developed in the home care environment, checking oxygen patients, when I got into home care in 1990, for example, the standard of practice in my market and many other markets was to send a therapist out once a month to check oxygen concentrated patients. We went in, not sure what we did sometimes other than check the concentrators, but we were doing monthly concentrator checks. Same applied to ventilator checks, same applied to apnea monitors, the same applied to CPAP as that started to evolve. So a lot of these things were developed as marketing tactics because in those same time frames, it was still common in hospitals for respiratory therapists to be doing oxygen rounds. Sometimes the rounds were done once a shift. Sometimes they were done once an hour. It varied by facility. Similar with ventilator checks. It was very common in those days back to be doing hourly vent checks. So we extrapolated from the activities that respiratory therapists were performing in the hospital, and so many of these were created to suggest that we were doing similar respiratory therapy at home. A big difference, though, was as opposed to applying the therapy itself as the therapist doing the actual administration, it was really much more teaching or consultation where we were training family, patients, and other potentially skilled caregivers to be involved, or unskilled caregivers to be involved in the provision of the therapy. So, as I said earlier, there really weren't and still aren't necessarily true standards of practice that are recognized. If you travel or if you've worked in different states, I have the opportunity to spend time in almost every state. There's significant variability in what people do. So what RTs do for one company in one state isn't consistent necessarily with what they do in another. Roles and responsibilities are similar, but some companies, the RTs aren't even involved in any way, shape, or form with the provision of home oxygen therapy anymore. Most of their time is spent, let's say, on CPAP, or if that company does ventilators. In other companies, they're very involved in oxygen. So again, it varies by market, it varies by company. If you've been around home RT for a long time, you know that the perceptions have changed. Early on, if you worked in home care, it was usually considered kind of the industry side of the business, meaning you really left being a therapist and you were now working for industry. In the early days, it was not uncommon to not be able to participate in many organizations as a member. I tell this story frequently. When I was moved into home care in '90 in Northeast Ohio, they had a Northeast Ohio Respiratory Care Managers Association, and it was for managers and directors to collaborate and meet on a regular basis. We have a lot of hospitals in Northeast Ohio. I was a director of clinical services at a home care company. I had staff very similar to my prior experience as a director in a hospital. So I signed up to be a member of this association, and I was rejected. And I was rejected because home care wasn't considered respiratory therapy. It was, again, still considered industry. So today, if you look at us, we've evolved to be a major part of the system. You know, we came out, we had home care specialty sections, and home care was recognized. We had our first section chair in 1993. We earned our first seat on the board in 2001 as part of the home care section, and we've continued to have a seat on the board of directors. Home RTs, once we got there, we've continued to do other things. We've served on the board of directors as at-large board members. We've served as vice presidents on the executive staff. We've served on the American College of Chest Physicians Home Care Steering Committee, NAMDARC. There are a number of AARC fellows that are home care therapists, and we're involved in lots of other areas of business. So I'd say the good news is we're legit. The bad news is that we became legit at a time frame when the market's been so dynamic and there's so much going on. So we do have a home care position statement, and there are a number of position statements within the AARC. Back in the late 90s, early 2000s, I had a chance to participate in rewriting it, and then it's been updated a number of times ever since. I won't read it to you. It's out there, but I think it's important that we recognize that the AARC does recognize the importance of what we do, just there's tough times. And I think right now, of all the time I've spent in home health care, this is the interesting irony of our period. At the time I believe home respiratory therapy is the most important, we having the worst period from a funding and resource standpoint. So again, if you look at where we're at today, obviously we have a lot more higher acuity patients. Patients come home still modestly sick as they transition. They're moving because we know it's the lowest cost point of care, and people want to be there. And obviously we have the technology to support that. Home care discharge planning in general is going under a major overhaul. It's identified as one of the leading problems associated with the readmission challenges. And then there's a number of new healthcare reform initiatives I'll talk about in a little bit that are focused on the outcome. And so at this time, so we have all this going on in the healthcare environment that suggests we should be putting more energy and more talent into the management of patients in the home. On the home care side, we're facing the worst reimbursement we've ever faced. The reimbursement for home medical equipment is the lowest it's ever been since the inception of the program. There are continued things out there, more bad guys out in the woods that we have to contend with. Obviously, the biggest being national competitive bidding, which we'll talk a little bit more about. We've got additional things happening in the private pay and Medicaid funding, and there's simply just less providers and clinicians available to provide the care at a time when we need it the most. This is just some of the current present pain that we felt, just to give you some perspective on oxygen just since 1997, when the Balanced Budget Act hit. That was at that time the single biggest reduction to the oxygen therapy payment in the history of the program. That was a 30% cut that took 25% one year in 1998, and then another 5% in 99, and also continued to hold CPI freezes. But you can see that over the remaining period following that, through 2010, we've either remained flat or continued to decline, tied to different legislative activities. And at the same time, our friends, the physicians, the skilled care and hospitals related have continued to see increases in their payment, even though they felt some pain. You can see, if you look at this graph version of it, shows you that from 97 to now, we've seen more than almost a 60%, at least a 50% decline in payment when you factor in all these different initiatives, and these are the milestones from the Balanced Budget Act, Balanced Budget Reconciliation, the Medicare Modernization, and the DRA, and the MIPA. So I'm not going to beat this horse too hard, but there's a lot going on out there that has been focusing on the reduction in payment, and I think it's not a hidden secret that much of the monies that came in from oxygen definitely helped to subsidize all the work that many of us do in respiratory therapy in the home, not just for oxygen patients, but for many of the other therapies that we do. We're continuing to have pressure. We've been living in with a round one, but that was a very small touch of only 9 markets. And in those 9 markets, we saw oxygen payments reduced by 33%. The entire category averaged a reduction of 39%. And overall, all GME that were in the bid categories was down 26%. The bids are in. We're all waiting. Many of you probably work for companies or run companies that are involved in round 2, and then maybe some of you participated in the bidding process yourself. While no one knows exactly what's going to happen, we know that 91 markets to round out to 100 total MSAs will go live in July of 2013. I can tell you from our surveys and private conversations and focus groups, most people believe the fee schedule is going to be at best equal to round 1 and potentially worse. So it doesn't look like there's any relief coming in the way of reductions in the financial pressure. This is just a map out. So if you haven't seen it, this is all the areas, the original areas, the second round areas that started out of 770, and then the 21 additional areas that came out of the Affordable Care Act. On top of the reductions, there's an audit pressure going on that's unprecedented as well. This is the greatest amount of audits with the most volume of audits, meaning different kinds of audits, and then the total volume of audits going on in the home care environment. It's also going on outside of home care. But I haven't met a company yet that isn't feeling some audit pressure, and I've heard many well-respected, experienced home care experts say that the audit pressures could have more negative impact than even competitive bidding as far as stressing companies and putting companies at risk of being placed out of business. So there's a lot of bad guys out there that are working on us, not bad people, meaning when I say bad guys, I mean bad events happening that putting a lot of pressure on the home care companies. And again, the results of this, at least the near-term data that we're seeing, suggest that the total number of home medical equipment companies is down, and there's been a steady decline in provider numbers over the last decade. I'll show you some data on that. There's been a reduction in the number of RTs working in the competitive bid market, and there's been cuts in non-competitive bid markets, but there's been some data to share on that. We've seen at least one large national public company disclose essentially releasing hundreds of respiratory therapists, disproportionately the majority of their RT staff, with the exception of a handful of states where RTs were required to provide certain services. And silently, there are reductions going on nationally. Most people don't advertise when they make a reduction in clinical staff. Lou Kaufman and the AARC collaborated on a survey last fall, and Lou went out as part of collecting data for a presentation he did at last year's AARC conference about the impact on HME companies to the RTs. And in Lou's survey, they found 61% of the companies in round 1 reduced the number of RTs on staff. Those same companies reduced the frequency of the visits, and about a third reduced the number of modalities they visited. So they picked product lines or service lines and just stopped doing home visits. In the current market, there's been some interesting changes going on, which are indicative of kind of the instability of the home care space today. We saw some global, big, and these are multi-billion-dollar gas companies that are very successful in providing home care in other parts of the world exit the U.S. market. Praxair exited in early 2011. Air Products got rid of their entire home care operations in 2009. And most recently, Homecare, which is probably by all objective data one of the largest, if not the largest, home respiratory company in the United States, just announced their sale to Linde, which is a German-based large global industrial and medical gas supplier. So those may all be good things for those companies, but it definitely talks about the dynamics and the instability of the market as it exists today. These are some of the data I referenced earlier. You look at just the total number of durable medical equipment provider supplier numbers over the last 5 or 6 years. You can see that there's a steady decline in the number of folks with provider numbers. Concurrently, if you break that down, because those provider numbers include providers for chiropractic provider numbers, pharmacies with provider numbers, rehab centers with provider numbers. But if you break it down and you look at the number of companies that bill Medicare between 300,000 and 1 million, with the exception of an interesting spike, there's a slight decline in the number of providers that are billing Medicare reasonably large numbers of dollar amounts annually. While this is all speculation, and this comes from the Van G. Miller Group or the BGM Group, which is one of the consulting and group purchasing organizations in the home medical equipment industry, they published some of their speculative data on their beliefs on the impact of competitive bidding. So you can see these data. I won't read them all to you, but clearly lots of jobs in both, and they're predicting that both contract and non-contract suppliers will go out of business as a result of it. And then even, in things that are part of the Affordable Care Act but aren't directly related, such as the medical device excise tax, will have an impact on jobs as well. So where are we going? Hopefully there'll be some light in this tunnel. The future, there's some new things going on. Obviously, I think everyone has heard of the Patient Protection and Affordable Care Act, or the Affordable Care Act, or often referred ACA, or often referred to as Obamacare. There's a lot of initiatives in there. I'm going to call out 3 that I think are getting the most attention right now.
Okay, folks, I'm sorry. I will call him and ask him to please try dialing back in. We just received an error message from our contractor.
Bill, I've still got
Joe. The line. Please bear with us for just a few minutes. Thank you.
Joe, are you still there? Because I still have you.
I'm here.
Okay, continue on with your presentation. Yeah, you continue on.
Okay.
Yeah, I'm sorry about that. It looks like Bill's losing his connection now. So we'll take care of him. Thanks.
Okay. Got it.
Okay.
Reagan, just let me know if there are any more problems.
Okay.
So sorry for the technical difficulties today. Getting back to discussion about the Affordable Care Act, the accountable care organizations, I'll talk a little bit more about those in detail, which are referenced as part of the Medicare Shared Savings Program. There are initiatives going on within the entire Medicare program focused on reducing hospital readmissions. I'll give you a little bit more data. There's some interesting telemedicine stuff, but that's not part of my big 3. And then, of course, the expansion of national competitive bidding, which we just talked about. The Affordable Care Act did touch on that. It actually added the 21 additional markets. So, as I said, round 2 was slated originally to be 70 markets. This added 21. Why 21? Well, the best data we have says 21 plus 9 equals 100. It gives you a nice even number for the number of metropolitan statistical areas being affected. So the future. ACOs are a big bet in Washington right now. We hear conversations about this just about everywhere on the Hill. There's a lot of belief that this is the next method or model for healthcare that's going to change what we do. Now, those of you who've been around a while have probably heard that at different points. We've heard it with DRGs and HMOs and PHOs and PPOs. So there have been a lot of programs introduced. ACO stands for Accountable Care Organization, in case I didn't say that. But Accountable Care, and I'll explain a little bit, is one of a number of initiatives going on. They announced 27 ACOs originally when the program was launched in April of 2012. This was affecting about 375,000 beneficiaries over 18 states. There was an existing pilot project going on, which was 32 programs that had been going on. So the new program as of April was affecting about 1.1 million of the Medicare beneficiaries. They just announced the second wave of this, which was 89 additional ACO organizations in July, which are going to care for an additional 1.2 million people over 40 states. Now, this is this is a program that is intended to kind of change the whole care model. If you look at what the criticisms of the healthcare model today is that it's a highly fragmented model, that it sets up for what are considered adversarial relationships, meaning the way you get paid in the hospital competes and kind of creates an adversarial relationship in the way you get paid in home health and in durable medical equipment and in skilled facilities. It's a focus on doing, meaning it's about volume. It's a fee-for-service, volume-based business. So the more you do, the more you get paid. And I think that's true not just in home care, but it's true throughout. You know, physicians get paid on CPT codes for procedures and activities. Hospitals get paid on admissions. And it's believed that this has produced a lot of perverse incentives, and again, the focus being on volume. In the ACO concept, it's about, I have a boss who uses the phrase, get all the liars in one room, and this is about getting all of these competing, or at least, you know, different interests related to the provision of care across the continuum organized into one business idea. So this accountable care organization is going to be an organization that's made up of physicians, hospitals, potentially home health, potentially skilled, and it's going to have a shared risk and shared reward. And again, this focuses on integration, cooperation, managing versus doing, team-based care, aligning all the financial incentives, and focus on quality and outcomes and efficiency as opposed to the volumes that are criticism. The second big part of the program out there are readmission reduction programs. All hospitals, unlike ACOs, which is a voluntary program that people sign up for and has a lot of stringent guidelines around, all hospitals in the United States that accept Medicare are participating in this Medicare readmission program. And they're looking at readmissions right now for a series of diagnoses, but ultimately expanding that. And this is focused on the fact that hospitalizations are, rehospitalizations are a very expensive element. It's estimated that 1/5, or about 20% of all Medicare beneficiaries discharged are readmitted within 30 days of their discharge. And you can see the numbers of more than half are readmitted within the first year. And when you start looking at high-risk diagnoses like COPD and CHF and some of these, the readmission rates are higher than the overall average. In COPD, it's almost 23% of COPD patients discharged are readmitted within 30 days. There's some big expenses associated with this. MedPAC estimates it's about a $15 billion per year expense. And Jenks, which is really in-depth, if you are going to read one paper about what's going on in readmission, read the New England Journal of Medicine paper by Jenks and colleagues on rehospitalization, where they examine a large database of Medicare patients over the course of a year. They estimate that this cost, the cost of preventable readmission, is at about $17 billion. So what's happening in that market? Last October, of October this year, the hospitals will be paid. They've been in a monitoring period right over the last year. And so they're going to begin to be penalized for readmissions that are considered preventable, starting with these first three diagnoses, which is acute MI, heart failure, and pneumonia. And then in 2015, these programs will expand to include COPD, CABG, P2CA, and other vascular conditions, so that they have a total of 7. And then again, there's additional opportunities for them to extend that. So what this means is that if a patient is admitted for one of these diagnoses, discharged to home, and then readmitted for any other, quote, preventable cause, the hospital does not get paid for that admission, and it gets marked against them for penalties that they will be able to be scored against them. First year is 1% of their total Medicare payment, second year 2%, and the third year will be 3% of their total Medicare. Why is this important? Well, if you look at where the spend is, a small subset of population, 10% of the Medicare beneficiaries, are 63% of the spend. And you can see that the per capita spend magnifies in that population. And of course, these are patients generally multiple comorbidity, closer to end of life, where the spends are quite significant. And so holding facilities more accountable for paying close attention to managing this higher risk population is what they're focused on. So for us, where's the future? Well, despite all these bad things that are going on out there, or perceived bad things, the patients aren't going away. We have 10,000 people a day turning 65 joining the Medicare ranks. We have COPD, which is one of the few chronic illnesses that's going in the other direction. So you have, it went from the 4th to the 3rd leading cause of death in the United States. You can see, lots of expense here, lots of time in the hospital, number 3 in acute care admissions. So COPD patients aren't going away. They're increasing in volume. Clearly that creates opportunity. So the question comes down to, and I think those of you who worked in hospitals in the 80s when we went through a lot of these changes, 80s and early 90s, respiratory therapy, when we stopped getting paid in hospitals and other settings for procedures and just started getting lumped into the DRG, went from a revenue-generating center to a cost center. And same things are happening in home care. We weren't ever really a revenue generator as far as being able to bill for our services, but there was enough opportunity within the revenue and in the profit margins of the things that we were associated with, the oxygen, the ventilators, the CPAP, that it subsidized the payment. Now those areas have been cut so bad that it's not able to subsidize. So many owners, many senior management, large companies start looking at respiratory therapy as a non-value-added cost center, NVA. Non-value-added is a term used in marketing, it's a term used in manufacturing, where if you have an activity that's not generating a return, it's either generating 0 return on investment or potentially a negative return, and if you stop doing it, nothing changes, meaning you don't lose business, then it wasn't value-added, it was costing, it was non-value-added. So if you look at this simply, if you're not adding value to the enterprise that you work for, you're adding cost. So when you think about what we do in the home, I believe that you break it down, there's really two areas that you can focus on. One is generating revenue, and the other is lowering cost of doing business within your organization. So where do you deliver value? Well, I think there's plenty of opportunities. I think that we are a hidden value. Respiratory therapy is an important and hidden value within the company. Patient education, disease management activities can drive significant value. If you're looking at, for example, the higher risk patients, the higher cost patients to manage, they're the ones calling after hours. They didn't listen. They had difficulty understanding how to use their equipment. There's compliance issues. So patient education and focusing on improving compliance, driving understanding of equipment can reduce unnecessary after-hours visits. If you can tie these into the continuum, a well-trained patient who's compliant to therapy, particularly in the COPD and CHF and some of the pneumonia and high-risk diagnoses that are being monitored, you can look down the continuum of preventing readmission. And there's some data out there that I'll talk a little bit about. You can help your company expand their business line. So there are things that we do that clinically nobody else can do, non-invasive ventilation, invasive ventilation. And I think that there's opportunities with the clinical teams to help formalize relationships with these hospitals and new organizations such as the ACOs, where the things that you're doing can be tied into the overall care of the patient and tied to these outcomes measures. And those outcomes measures can be very important and meaningful as we continue to go down into these new models of care. Referral source education, I think the respiratory therapists are, that the opportunity for being involved in sales-related activities is a good thing. And this is, when I say sales support, you don't have to be as a clinician out there selling, but supporting the sales, continuing education programs, educating referral sources and clinicians about the new technologies that are available. You'd be quite surprised. I just had a conversation this morning with a customer who was in our offices for Business Day that he's been out interviewing discharge planners and case managers and was quite surprised at how many of them had never seen the equipment that they're prescribing. They're totally unfamiliar with the equipment that they actually are calling in and writing orders for. And so as the technology continues to advance and there's more innovation, the opportunity to be out there educating and using information to train them on non-delivery per se, or using a formulary approach to CPAP technologies and PAP therapies, which have myriad products that'd be impossible for a big company who's trying to be cost effective and run a lean operation to carry. Standardizing protocols, getting physicians and facilities to allow you to go a little bit more standardized in your approach towards treating the patients. I think there's opportunities here to track clinical outcomes and outcomes data. There's a number of talented RTs and companies out there, Kling & Smith and Dan Easley and Kim Wiles and Luke Hoffman, who have recently published work where they have been working with hospitals and payer sources to use their RTs to go out and do clinical education and follow patients to reduce readmissions and drive up compliance. There's opportunities to change the way we do it. Just because we've been doing things a certain way doesn't necessarily mean we're doing it right. There's operations to develop new models. So driving around chasing CPAP patients, for example, might be better managed by having them come into clinic. They went into clinic everywhere else to get treated. The doctors didn't go visit them in the home. In most cases, the sleep labs didn't go visit them in the home. The primary care doctor's not visiting them in the home. But we're running out, changing masks, adjusting CPAP settings. And so a number of companies have moved their PAP clinics internally and have had very, very successful models with PAP clinics. Same opportunity may exist for oxygen evaluation and titration clinics. So bringing patients in, they go to pulmonary rehab, they go to their physician offices for follow-up. Does not necessarily mean that we have to do everything that we do for them in their home. I mean, I've seen similar with apnea monitor patients who are seen in clinic, sometimes in joint clinic. The home care company goes to the NICU clinic and visits those patients as they come in, and they do the downloads right there on site. So there are opportunities to drive efficiency in your clinical models. Doing things just because you did them doesn't mean you have to do them. For example, concentrators. Many of the modern concentrators today don't require routine checks at 6 months. Some are a year, some go out as far as 3 years with the sensors. So if we're going out every 6 months checking equipment, that's like checking the oxygen, making oxygen rounds and checking oxygen bottles every hour and making sure flows are set. Those are things that didn't add value, didn't add clinical outcome, didn't tie into outcome, and so the opportunity to break from those existed. And as an extension of that kind of sales support, local marketing. There's a lot of opportunity. Patients want to learn. There's a lot of opportunity to get out and educate consumers, and those educated consumers become good customers. So working with better breathers clubs and pulmonary rehab groups and sleep support groups and other things create opportunities within your company. And as the clinical experts and as the experts that can talk to the patients, talk to their referral sources at that level, you create opportunity in your business by driving sales and marketing. So I think really today the model that we've lived with, where product was subsidizing payment, just isn't sustainable. And the irony is, as I said earlier, is that the care, particularly that we do now, is probably more important now than any other time we were doing it. With all these measures, quality matters, outcome matters, and total cost of care is incredibly important in these new models. So where do we get paid? Right now, one of the most common responses I hear to this is, well, it would be great if I could get paid for it. And there's been long-term campaigns from the AARC and others trying to find a way to get direct payment for respiratory therapy services in the home. And while we haven't given up that battle, it hasn't happened yet, so we still have to survive in the interim. And I think as we go forward, that future payment models may come from other sources. Right now, the DME benefit is the subsidizer, but I think other models may develop. There are obviously legislative activities such as the AARC's initiative with HR 941, which is to have certain codes, CPT codes, be able to be serviced by respiratory therapists working under the physician. But also this with the hospitals at risk for readmission, with ACOs ultimately at risk for a patient over the total care across the continuum. They may become sources of payment. They may actually look for subcontracting opportunities or relationships where they're invested with partners who help them lower total costs in other places. And potentially downstream, as insurance continues to change, the patients and caregivers themselves. There are a lot of self-pay activities going on out there in the healthcare market that may create opportunity. There are many private pay care opportunities that are going out for health aides and folks buying telemedicine systems for cash and paying out of pocket. So there may be new opportunities that 20 years ago seemed impractical or improbable, may become payment models that exist in the future. So as we kind of wind up here, I wish I was able to predict the future, because if I could do that, I'd probably be on a yacht somewhere calling in my orders to Wall Street for stock purchases. But since there's no accurate way to do that, we take some, our best guess. And I think that there are a couple certainties. Payments for home medical equipment are clearly going to continue to face financial pressure, and the fee schedules are going to go down. And that's going to make cross-subsidization between product lines and services much more challenging for many companies. At the same time, demand for home care services is clearly going to grow. We have an aging population, chronic disease is growing, and we are the lowest cost of care. The home is definitely a place where you want to be providing care in the future. This means things have to change. Payment methodologies, how we get paid, the incentives, the drivers will change over time. And quality and outcome-oriented care will be at the top of the list. And how they spend money is going to be very important, especially in the risk models that are starting to occur, such as the accountable care organization. And I think that in the middle of this, home respiratory therapy is a critical element. And we're there, right there in the middle of a lot of these diseases. We can make an impact. There's data starting to support that we make an impact. But it's going to be some rough seas as we go through these changes until we get there. So with that, I'm going to wrap up. Reagan, Bill, if you're on the line. At this point, I'm finished. Again, I apologize for any audio difficulties we had out there. Hopefully, the balance of the lecture was okay, and I'd be happy to take any questions, Bill.
Thanks, Joe. Folks, this is your time to get your questions up on the discussion board. We will be addressing a few of the questions that were raised earlier in the presentation. Joe, I want to thank you for a great overview of where home respiratory care has been, where it may be going, and identifying where the opportunities are. And I can only tell you that just this morning I sent out to the management section a link to the Kaiser Healthcare website, where they have listed all of the hospitals in the United States and how much money or what percent of their Medicare revenue is going to be withheld because of their previous performance on readmissions. So that is reality. The hospitals are going to be reaching out to wherever they can reach to try to reduce their readmission rates. And you predicted there's going to be coupling with home care companies and more arrangements with home care companies, and I believe you're absolutely right. And I also recall those days that you referred to, the days of yore when home care therapists really weren't respected by the community. And it's certainly interesting that has come so far, where they are now very much respected and very much a part of being able to keep patients enjoying the best level of health they possibly can. We do have some questions. Again, I want to remind you, put your questions up in the box there. I'd lost some questions when I lost connection with the program earlier, but I do have a few that we got started that I had before I got disconnected. Someone asked if I would have you discuss VPAP if time permits. Can you make any statement about that, Joe?
About VPAP?
Yes.
Is there more specific to the question?
No, it just asked if you would discuss VPAP. Maybe you could just define what it is and tell us a little bit about it.
Well, I'll be honest, I'm not an expert. So,
okay.
As far as
we can move on.
Some of the new modes of ventilation and non-invasive ventilation, so I probably, without doing a little research, probably wouldn't be the best, unless there's more specific questions about reimbursement or something like that.
No, it's not.
Applications for disease.
Yeah, it's just a general question. Let's move on to the next one then. One person asked, how can respiratory therapists help decrease Medicare and Medicaid fraud and abuse so that state and federal governments see us as a positive influence on healthcare costs?
That's a great question. I think as an industry we're trying to point out that the vast majority of companies are doing the right things. Again, I think as respiratory therapists, the best opportunity is the grassroots opportunity when you talk with senators and congressmen on your local basis. I think that they only hear the sound bites of the bad guys. And disproportionately, the vast majority of home care companies will never be in trouble for fraud, Medicare fraud or Medicaid fraud issues. But when the CMS or the OIG or others get that information and they jam it through the ranks in Washington, they communicate that information quite effectively, and that's what the legislators see and hear. What makes the biggest impact is when they're home visiting their home territories, you can invite them out to your company, or you can go get your opportunity to be in front of them and explain what you do and who you are and how the high level of care and service that you and your companies provide. That has the greatest impact by far.
Okay, thank you. One person notes that in audits of DME files, she wants to know if there are companies having to send money back to Medicare due to not having all the clinical information needed on file, that is, not having proof for certain DME modalities.
The short answer to that is yes. There are definitely companies in audits who are being penalized. There's companies that are being placed on prepayment, 100% prepayment reviews. And again, what they're looking for, when you say clinical information, generally what they're looking for is documentation, the chart notes, follow-up notes from the physicians, evidence that the patients are using clients with therapy, things like that. And so, yeah, the short answer is yes. In the audit process, lack of documentation is the culprit in many of these cases.
Okay. Joe, there's a question that focuses on telemedicine as an option for the home care respiratory therapists. The question is, can telemedicine generate revenue for DME providers that employ respiratory therapists?
Well, in the short term, there really isn't any direct reimbursement for most telemedicine initiatives. Most of the telemedicine activities that are going on out there right now are either grant-funded, part of special pilot programs, or incorporated into programs like in the home health, where they're trying to integrate elements to help lower the total cost or manage patients within certain programs like congestive heart failure and stuff. Long term, there may be direct payment for telemedicine. I think telemedicine is a pretty big word. It reminds me a lot of saying like disease management or discharge planning. These are very broad terms that cover a lot of elements. And telemedicine is one of those kind of terms right now that covers a lot of different areas. I will tell you, if you're interested and you're in the home care industry, there is an organization called the American Telemedicine Association, which is a large growing organization. Membership is relatively inexpensive, and they have an annual conference. And if you want to get a feel for the different direction and the approaches that are going on in the telemedicine space, it's an interesting organization to participate in. And again, the technology is the roadmap for where they're headed isn't completely clear, but clearly there are a number of research projects going on in the telemedicine space, looking at different technologies and different disease management approaches. Again, mostly focused around these high-risk chronic conditions or patients with multiple comorbid conditions.
Joe, there was a statement made about offering free CEU programs. There was one of our listeners posted this on the discussion board. It says free CEU programs could be considered by Medicare to be an enticement for referrals. Federal law restricts this practice. Could you maybe clarify somewhat what you were saying about offering continuing education?
Well, again, I think that's open to interpretation. One, it doesn't always have to be free. But quite honestly, most facilities won't allow you to come in and present these days unless you can tie it to specific education. Continuing education, if it's general, I would defer to your lawyer, but it's standard of practice. It's a common business practice to use continuing education as an opportunity to get in front of referral sources and to present information to them. So, while the inducement language is quite broad, if you're using continuing education as a part of a conversation in conjunction with a referral source that is standard of practice, I would defer to your legal counsel to guide you as to whether or not they believe that would cross into the inducement rule.
Joe, we're just about out of time. We're about 3 minutes from the hour, so I'm afraid I'm going to have to cut the discussion off here. I do want to thank you again for a great presentation. I apologize to everyone for the audio difficulties we encountered. Joe, we apologize to you as well. But sometimes when you're dealing with technology, those things just happen, and this was certainly one of those days. Your slides were great. There's a lot of great information in there. We will have this presentation back. We will have it archived and back up on our website, hopefully within the next week or so. So, to those of you who are watching this as a live presentation, please stay with us during the next brief pause for instructions on how to obtain your CRC contact hour. If you're watching this program as an archive, this concludes our presentation.